Good evening, sir. Good evening, sir.
So, good evening to all of you. Today we are trying to attempt something little different in the grand rounds compared to what we have been doing all this while. All this while, what we used to do is we used to take one index case and then we would discuss that case in detail with the from the basics onwards to the management and the insights that we get. In one grand rounds, we went into the details of how to manage the pharmacological management of vestibular migraine. This time, I wanted to do something a little different, and that is book reading. The reason why I thought the reason why I thought book reading is also important is personally I felt a lot of benefit out of that, and we actually what happened is during the COVID pandemic, okay, when it was all locked down and those things were there. At that time, there are four of us. Okay, Dr. Pratik is here online, Dr. Pradeep Undavalli, and then Anantu. Four of us would get up every day in the morning around 5 a.m., sometimes earlier than 5 a.m. like that, and then read for 2 hours. And through that process, we could complete the Neurology of Eye Movements entire book by Z. And later on, we started doing some more books also. But when it comes to the utility to a clinician, so far as a clinician who takes care of patients with vertigo, so far the most useful book that I have found is Adolfo Bronstein's Dizziness, the book Dizziness by Adolfo Bronstein. And that also is one book which we regularly read in the clinic together. Okay, so all of us. So what I will be doing right now is reading for you. Okay, the way we read. Okay, that is more of a demonstration. Also, there is a lot of knowledge and insights that we'll be doing. So it is clear-cut, simple, plain reading and analyzing, summarizing, and that is it. So with that, let us start off. The chapter that I have chosen is this chapter 6. Okay, please let me know whether all of you are able to see the.
Sir, we are able to see.
You are able to see. Okay, Vishnu, you will be able to do the. You will be handling the admitting people, right?
Yeah, sir. I'm managing.
Okay, so if you're managing that, then I will not bother about that. Okay, so now I'll start ahead. So chronic dizziness and unsteadiness. And he starts off by reflecting our thought that is perhaps the most dreaded of all patients with balance disorders is the one with the long-standing continuous dizziness. If you are an ENT doctor, this patient may have already seen a neurologist. If you are a neurologist, your patient has definitely seen an ENT specialist. If you are a neurologist, the patient is likely to have seen both an ENT specialist and a neurologist. The patient almost certainly has had many sophisticated tests, including brain scans, audiograms, neck x-rays, and maybe vestibular function tests too. So what are we going to do? It may be useful to separate this question into two parts. So this question as what are you going to do can be dealt in two parts. What do patients with chronic dizziness have? Means what is the underlying cause? Why are they dizzy chronically? Second thing is what can you do for them? Once you know or don't know what they are going through, or what is the actual cause, what can you do for them? Now, table 6.1 lists the main conditions presenting with chronic dizziness, and table 6.2 provides an overview of the approach to this difficult patient. So even before we read the chapter further, let us go ahead and take a look at the table 6.1 and 6. Table 6.1. The main conditions are grouped as those with and without physical signs on examination. These are very important. Everything may not have physical signs on examination. The conditions listed in the table are in no particular order of frequency, but we start with bilateral vestibular failure and the syndrome of downbeat nystagmus because they are often clinically missed. The reason why he is starting off these things, the list with bilateral vestibular failure and downbeat nystagmus syndrome is not because they are the most common in terms of frequency, but they are things which can be missed clinically if not specifically looked for. So condition or syndrome and key features. They start off by conditions with physical signs, and then they go on to conditions without any physical signs. So let us go ahead and go and see the conditions with physical signs. Now we are dealing with chronic dizziness. Conditions with physical signs is bilateral vestibular failure, downbeat nystagmus syndrome, neurological gait disorders, orthostatic hypotension. So let us see. And most of these things, once you are aware of them, should be straightforward. Let us see. Bilateral vestibular failure. The key clinical features are bobbing oscillopsia when walking or driving. Bobbing oscillopsia when walking or driving. Unsteadiness, which is worse in the dark. Bilaterally abnormal doll's head maneuver and a head impulse test, vestibular tests are useful. So very nice. He has told that in this particular condition of bilateral vestibular failure, vestibular tests are useful. The clinical features, the patient complains of bobbing oscillopsia. Bobbing means up and down movement. Okay, bobbing oscillopsia, up and down movement when walking or driving. Because when we walk, our head moves up and down. The eye does not make a compensatory movement. Therefore, you start seeing. The person starts having a bobbing oscillopsia. Head movement is up and down. The oscillopsia is up and down. Unsteadiness. Patient tells they are unsteady, and if you specifically ask a question, is it worse in the dark? You say yes, it is worse in the dark. Bilaterally abnormal doll's head maneuver, okay, which means, okay, if you do the head movement, okay, right, left, the compensatory eye movement in the opposite direction is non-existent, and head impulse test is also bad. And vestibular tests are useful. Okay, when he says vestibular tests are useful, the common vestibular test that we may employ in this particular patient can be a clinical chair rotation test, a clinical VNG based, okay, chair rotation test. When they talk about, then we can do a caloric test and we can do a head impulse test, and all the tests will show reduced semicircular canal function. Then he tells downbeat nystagmus syndrome. We have to reiterate the first two things have been mentioned here. Chronic dizziness. In chronic dizziness, condition with physical signs. First two things are mentioned: bilateral vestibulopathy, bilateral vestibular failure, and downbeat nystagmus. Not because they are more frequent, because they can be easily missed if not specifically looked for. Here the thing is slowly progressive unsteadiness. The oscillopsia is again vertical oscillopsia. There can be downbeat nystagmus seen. Occasionally, there can be additional cerebellar findings like speech. Okay, the speech may be cerebellar type. Okay. The one difference between the downbeat nystagmus vertical oscillopsia and the bobbing oscillopsia of bilateral vestibular failure is, in bilateral vestibular failure, the bobbing oscillopsia is when walking or driving. In downbeat nystagmus, this oscillopsia is even when the patient is at rest and not moving at all. So this is a very important differentiation. Then coming to neurological gait disorders, okay, this is dealt with in another separate chapter, that is a chapter 7 in this same book. Okay. Then it is also further dealt with in table 6.2. Peripheral neuropathies, spinal cord syndromes, that is cervical myelopathy. This is cervical spondylotic myelopathy, where there is a pressure on the anterior columns. Cerebellar diseases, which can be with the downbeat nystagmus syndrome, that is the top, or without downbeat nystagmus. Cerebral disorders like Parkinsonian syndromes and small vessel white matter disease. These are all the neurological gait disorders we should be aware of. We will go to table 6.2 later on to go a little more into detail. Then coming to orthostatic hypotension, common in the elderly, especially who is under antihypertensive drugs. Dizziness or pre-syncopal feelings while standing relieved by sitting or lying. BP drop on standing from supine greater than 20 millimeters mercury systole. There are very nice points here. Orthostatic hypotension. It is common in a person who is taking, in an elderly person who is taking antihypertensive drugs. Lot of times there can be pre-syncopal feelings, which is relieved by lying down. A person with benign paroxysmal positional vertigo feels vertiginous on sitting up, feels vertiginous when going back to lying down. A person with orthostatic hypotension feels vertiginous on sitting up or on standing up, but feels better on lying down, feels better on lying down or sitting down. Now, so we all started off by chronic dizziness, the common diagnosis that we need to keep in mind. And in that, conditions with physical signs, we saw 4 conditions: bilateral vestibular failure, downbeat nystagmus syndrome, some neurological gait disorders, and orthostatic hypotension. If we look for, if we are aware of them, these things will become easy to diagnose because they all have physical signs. Now we'll come to conditions with no physical signs. There is a condition called as chronic vestibular migraine, which is elaborated in the text. We'll go to that later. Key features are low-grade dizziness. There is a nausea and migrainous feature following recurrent vestibular migraine. Okay. Then poorly compensated vestibular disorder. Okay, this is patient has a vestibular disorder which has not been well compensated. Okay, this is a patient with past history of vertigo. We'll understand this concept a little better when we start reading this more. Residual dizziness after acute or recurrent vestibular event. This is poorly compensated. Additional syndromes requiring special treatments are common, such as, okay, triple PD. Here it's only double PD. Visual vertigo. Okay. All these things are written in this chapter. We'll read that. Persistent perceptual dizziness. Okay, this is same thing. There have been different synonyms for this: phobic postural vertigo, chronic subjective dizziness, psychogenic dizziness. This chronic subjective dizziness is a little old term. Phobic postural vertigo again is a little old term. The reason why these terms have been replaced by persistent perceptual postural dizziness or double PD or triple PD is they say that in Europe they don't like the term chronic. Chronic means that somebody is going to all the time have it and the person is not going to be ever relieved of it. So they wanted to remove the negative connotation of that. Therefore, instead of chronic, they started using the term persistent. Okay, this subjective started telling that, okay, there is nothing objective inside. So that also was having a negative connotation. So instead of making it subjective, they started making it perceptual. So it is like that how this term chronic subjective dizziness evolved into persistent perceptual dizziness. Okay, that is all it is. Okay, so vestibular, general medical or psychological trigger may be present. There can be, for this condition to develop, there may be a vestibular trigger, there can be a general medical trigger or a psychological trigger. Patient is very likely to tell that, to even tell the specific day or date from when all these conditions started. I was fine until this or that happened, like that. Other medically unexplained conditions are common. Minor vestibular findings are possible, but out of proportion with the symptoms. So now we saw, just to restart, we are dealing with this chronic dizziness and unsteadiness. It starts with saying that this is a very dreaded of all the groups of patients when it comes to the doctor, because they have already seen an ENT or both ENT in neurology. And if you are a neurologist, they would have seen both. Okay, so that is how it comes. They come with a lot of investigations. And our task would be what is going on in them and what we can do for them. So to begin with, the authors start with giving one table of findings, chronic dizziness, the diagnosis that can be there, and they group the diagnosis into conditions with physical signs and conditions without physical signs. When it comes to with physical signs, we have BVP, bilateral vestibular failure, downbeat nystagmus. Key difference in Bilateral vestibular failure, bobbing oscillopsia is there. Bobbing oscillopsia is there during the act of walking only. At rest, it is not there. In downbeat nystagmus syndrome, there is a vertical oscillopsia, but that happens at rest. Neurological gait disorder and orthostatic hypotension. Orthostatic hypotension has a very specific finding, and that is you can document a drop in blood pressure of greater than 20 millimeters of mercury. In fact, this kind of drop in blood pressure can be even better manifest after the patient has had a meal. So sometimes we in the clinic send the patient to go have a meal and come back. Therefore, we can really unmask orthostatic hypotension. What is mentioned here is an elderly patient taking antihypertensive drugs, but we also see patients who are taking drugs for benign prostatic hypertrophy. BPH patients, in fact, in our practice, BPH patients are among the commonest group to present with orthostatic hypotension. BPH patients on medical management. Then conditions without physical signs, he introduces a very nice term called chronic vestibular migraine. Then also tells about poorly compensated previous vestibular insult, which has not been compensated well, and then persistent perceptual dizziness. Now, there is a very nice way in which the authors take us to tell us how to proceed with this. And the starting point is a nice point to start off for these particular patients. I'll get into that. So part of the problem in trying to understand what's wrong with the chronic dizzy patient is that they can describe their problem in many ways. They can feel dizzy or giddy in the head, including sometimes mild rotational feelings, a bit drunk, detached, slightly off balance or unsteady, that they seem to veer to one or both sides while walking, that they feel more steady if they touch or hold on to a furniture, that they feel as if they were walking on a mattress or on cotton wool. These symptoms are fairly constant, but there may be minor fluctuations. That is bad days and good days. We feel that the description of the current symptom is important, but perhaps not as useful as the description of the history of the symptom. See, the authors spend a few lines telling what all ways in which they will describe the symptoms. They also tell that there are good and bad days. They also tell about that these patients feeling a little better if they hold on to something. Okay, that is not strong enough to prevent them from falling, but just hold on to a little bit, they feel better. But after all these things, they stress all this description of the symptoms is less important. What is more, of the description of the current symptom is less important, but perhaps, okay, is important, but not as important as the description of the history of the symptoms, like what happened before or how the disease is progressing. So there are essentially three types of history when it comes to history of the symptom. The patient who started with one or more attacks of rotational vertigo. Today, the patient is coming to us with chronic dizziness or unsteadiness. But how did it begin? All this began, the patient says, with one or more attacks of a rotational vertigo. That could be possible. The other type of beginning is, other type of history is the patient with progressive history of disequilibrium. Here, there has never been an attack of rotational vertigo before, but they are starting with a progressive history of disequilibrium. And then the third category of patient, it is not progressive in the sense there is no worsening. Okay, it is the same. Day to day, it is not worsening. Vishnu, can you handle the other mics? Okay. The patient with progressive history of disequilibrium, patient with neither of these. Okay, so these three groups are. When the table was made into conditions with physical signs and conditions without physical signs. Now the description is going to be a little different. It is going to be based on patients who are now chronically dizzy, but dizziness began with acute vertigo or recurrent, either one attack or more attacks of rotational vertigo. The other group is no rotational vertigo history before, but it is the disequilibrium is progressing. And the third group is there is no progressive also. There was no history of the disequilibrium is not progressing. The imbalance feeling is not becoming day by day worse. That is not happening. It did not begin with a rotational vertigo. Neither of these things, there is a third group which he wants to deal with. So these are the things. So let us deal with the first group which he talks about, the authors talk about, patients with a past history of vertigo. These patients report that at some time in the preceding months or years, they suffered one or many vertigo attacks. Detailed history taking should let you reach a retrospective diagnosis of either vestibular neuritis, it would have been a single attack, benign paroxysmal positional vertigo, or other conditions that are discussed elsewhere in the book. In this case, the patient will acknowledge that he or she does not currently suffer from the disabling rotational vertigo. Benign recurrent vertigo, they can easily distinguish between the acute recurrence and the chronic dizziness. In this case, the chronic dizziness tends to increase after each vertiginous episode. Okay, so we are dealing, the authors want to deal with this chronic dizziness into three groups. A group which began with rotational vertigo, a group which did not begin with rotational vertigo, but the unsteadiness is progressing day by day, and the third group, it is none of these things. Now, in the first group, which it began with vertigo, okay, there is a possibility that it is those rotational vertigo attacks are not happening now. There is also a possibility that the person's rotational vertigo attacks are coming now also, and in between also the patient is having dizziness. In between also the patient is having dizziness, fine, and that dizziness typically worsens if the patient has had a another rotational vertigo attack. So it is like this. This is the kind of feature. Now let us go a little more. Few published data are available, but it is known that these patients are extremely common in specialized clinics. A patient who started with vestibular neuritis will describe that, say, 10 months ago he had the flu and then severe vertigo, nausea, and imbalance for a week. He saw a doctor at that point and was told that he had a viral infection of the inner ear, that the symptoms would progressively go away and that he would return to normal or near normal within 2 to 3 months. Instead, indeed, the majority of patients do recover fully within a few months, but a small proportion does not. Unfortunately, because acute and recurrent vertigo are so prevalent in the general population, this small proportion of patients make up considerable number of patients. Okay. So what can be happening here? Why do some patients not recover fully after one or more episodes of vertigo? We suspect that long-term symptoms are the consequence of some difficulty in the process of vestibular compensation. The process of central vestibular compensation is complex, and it is often difficult to ascertain in each individual patient what may have interfered with the fine-tuning required to achieve full compensation. Possible causes are sometimes apparent. For instance, if there is an associated visual peripheral nerve, that is proprioceptive, or central neurological problems, reduced mobility or advanced taste, which has all of the above. Often, however, the cause is not apparent, and in patients with anxiety, depression, or other medically unexplained symptoms, one is tempted to attribute the chronic disease symptoms to a psychological problem. This will be discussed further under persistent perceptual dizziness below. At the moment, there is no definitive conclusion as to the exact mechanisms leading to chronic dizziness in patients with previous vestibular vertigo, but there is agreement that the problem is multifactorial and the solution has to be multidisciplinary. Some specific syndromes of patients with chronic dizziness have been described, and although the interpretation of these syndromes is still somewhat controversial, the reader will benefit from being familiar with the different modes of presentation in the clinic. Furthermore, regardless of the specific path into these syndromes, successful symptomatic treatments are available to them. So this particular section of Adolfo Bronstein, this particular section starts off by telling that there are people who have had one attack of vertigo. There are people who have had an attack of vertigo, who say a vestibular neuritis. Most people who have had a vestibular neuritis in few weeks to few months will return to normal functioning. But there are some proportion, okay, very small proportion, but the population is so huge, the general population, this small proportion becomes huge in terms of absolute numbers, becomes huge, who will not return to normal. Everybody else returns to normal, but few will not return to normal. Why don't they return to normal? What could be happening in those patients who don't return to normal? What are the other conditions they may be having? So possible causes are sometimes very apparent. There may be other associated problems with their vision, with their peripheral nerves. There may be a proprioceptive loss. So there may be reduced vibration sense. There may be in the lower limbs. Okay, the joint position sense is low. Okay, or they may be having central neurological problem. There can be overall mobility itself is reduced of the patient, or the patient may be having an advanced age. There can also be a patient in person who goes into this kind of a disease who refuses to compensate. Okay, after a vestibular neuritis, who refuses to compensate for a long time. That could be a person who probably after a post-vestibular neuritis also has developed a benign paroxysmal positional vertigo. And because the BPPV was not corrected, that also is something like an associated problem. Here we talk about associated with visual, peripheral or central neurological. There can be associated other vestibular issue also. All of those things put together may not be, or individually may not be allowing the person to compensate. Okay, and the moment you treat the benign paroxysmal positional vertigo, okay, from this is my experience that I'm talking about. The moment you treat the BPPV of that particular patient, then the process of compensation starts off and the patient starts becoming better. Now, with these patients who refuse to become chronically dizzy, there are some specific conditions that have been given because they have specific features. And these specific conditions are, one condition is called visual vertigo. There is another condition called motorist disorientation syndrome. And there is another condition which is called persistent postural perceptual dizziness. Okay, so these are the things that we will be dealing with a little more in detail each of. And then there are other psychiatric dizziness syndromes. And then chronic vestibular migraine, late stage Meniere's disease. Okay, so many things are there. So we will come to each of these things. So where are we now? We are now dealing with a patient with chronic dizziness. And in the patient with chronic dizziness, we are now started off with a patient whose dizziness began with rotatory vertigo, or has ongoing attacks of rotatory vertigo, or it started off with rotatory vertigo, which is no longer there. But in the history, there is this episodes, single or multiple episodes of rotatory vertigo is there in this particular patient. So in that particular patient, there are some known specific syndromes which we will be dealing with. So visual vertigo is one of those things. These are patients with chronic dizziness who report that their symptoms worsen in certain visually busy surroundings. The syndrome is given different names such as visual vertigo, visuovestibular mismatch, space and motion discomfort, and perhaps more accurately, visually induced dizziness. Frequently reported trigger situations are walking through the shelves in the supermarket aisle. So when they go to the supermarket, they go in the center, both sides, the shelves move. The image of the shelves move both sides. So this is one of the trigger situation. The other name given to this is supermarket syndrome, sometimes called the supermarket syndrome. Viewing movement of large visual objects such as clouds, wind-swept trees, water flowing river, disco lights, moving crowds, traffic, curtains being drawn, films with car chase scenes. this water flowing need not even be river. We have a patient in home, just opening the tap in the bucket to fill, even that makes her dizzy. Okay. So there are so many of these trigger situations in which there is optic flow of information on the retina. There is flow, okay, of movement of the entire patterns, and that will cause dizziness in this patient. Repetitive visual patterns like stacks of cans in supermarket shelf, ironing striped shirts, or walking past a repetitive patterned fence also seem to be relevant. Some patients also mention that moving the eyes, reading and flickering or fluorescent lights can make them feel dizzy. This is a very important point to note. All these other symptoms, other things we mentioned so far here are objects or things in the world moving. Whereas when it comes to here is authors are talking about the subject moving their own eyes, which makes the world move. Okay, if you move the eyes itself, the world on the view of the world on the retina moves. So that also can. There are people who come to us and tell, when I look right, left very fast, I feel dizzy. So this is the kind of thing. Where do they come under? They also come under visual vertigo. Reading and flickering, even reading a book where there is, okay, the rest of, see, when I read a book from one word to the other word, my vision jumps. Okay, in the periphery of the retina, the entire field has moved to one side. Or fluorescent lights can make them dizzy. We know that in many of the situations described, the visual environment contains too much information. That is the optokinetic stimulus provided by the supermarket shelves, or that self-motion information conveyed by visual and the vestibulo-proprioceptive symptoms are not in agreement. For example, movement of large visual scenes is normally interpreted as self-motion, but is in this case is not corroborated by or is in conflict with the vestibular system. That is sensory conflict. I want to go a little bit more detail. I'll stop reading at this point of time to explain this particular concept of movement of large visual scenes is normally interpreted as self-motion. See, when we were hunter-gatherers, when we did not have all the TV screens and all these things, when we are out in the open, whatever. Okay, so a large visual scene movement, when you did not move, was only possible probably when you are looking at the clouds, when the cloud moved. That's all. When you are upright and looking at the outside world, okay, if the entire vision, if the tree moved from one side to the other side, it doesn't happen. Okay, the trees cannot move from one side of visual field to the other side on their own. It can happen today when we are sitting in the train and when we are moving in the train, the trees from one side go to the other side. Okay, so basically that also means that the person is moving. So if the entire visual field moves, that is only possible. The entire visual field moves from one side to other side. This is only possible when the person has moved. So if I rotate in one direction, the entire visual scene moves in the other direction. Otherwise, it is not possible that the entire visual scene moves. Therefore, full field visual movement is interpreted by the brain as the person moving. That is what it is. So in this particular person, the weightage given, a person who has a vestibular deficit, the weightage given to the visual symptoms goes on to vision, goes on increasing because the vestibular input is unreliable. They start using visual input to tell whether they are moving, whether they are straight, whether they are oriented vertically, all these things. So because of the increased weightage, now large field visual motion is interpreted by the brain as the person moving. But that interpretation does not corroborate with the information that is coming from the vestibular system because the person has not moved. So there is going to be a conflict. We also know that all patients with vestibular lesions are prone to be influenced by visual stimuli as part of the sensory substitution process that takes place during vestibular compensation. Furthermore, research has shown that patients with the visual vertigo syndrome are visually dependent. That is, in them, vision is the predominant stimulus driving balance and spatial orientation. For these reasons, it should come as no surprise that intense visual motion stimuli and visuo-vestibular conflict can produce a disorientation, imbalance, and dizziness. Although the reasons why only some vestibular patients develop visual dependence and visual vertigo are not known, fortunately, their symptoms can be improved by progressive exposure to visual motion stimuli and visuo-vestibular conflict during the rehabilitation program. See, now let me again come back. This is what we call as a Simhavalokana Krama, the way a lion moves in the forest. The way a lion moves in the forest is it takes 10 steps, it looks back, again takes 10 steps, and then again looks back to see how much it has covered. So that is how we are supposed to be seen. This is called Simhavalokana Krama. Simha is the lion, Avalokana. Okay, that. So we all began with seeing the patient with chronic dizziness. Okay, we went to conditions with physical signs, conditions without physical signs. Then we took a different approach, the origin of chronic dizziness, whether it began with an acute attack of vertigo or recurrent attacks of rotatory vertigo, and now the patient is also chronically dizzy, or no previous history of rotational vertigo or current history of rotational vertigo, but patient is becoming progressively disequilibrium, progressively unsteadiness, or neither of these things. And within that, we started dealing with the patient with a past history of actual rotational vertigo. There we saw one example of a patient with vestibular neuritis. Well, most of them compensate. Why some people do not compensate? If they don't compensate, possibly they have other predisposing factors, like their vision is not great, their neurologically is not great, or proprioceptively not great, or maybe we also consider from personal experience, maybe they have another concomitant vestibular condition like BPPV, which is stopping them from compensating. Now, when they don't compensate, they can get into some named syndromes, and one of that named syndrome is the visual vertigo. And the authors, when it comes to the visual vertigo, the authors tell different kinds of experiences seen by the patient. They tell us the importance of why these people become visually dependent, because the vestibular signal is not that reliable. The vision is the predominant symptoms which helps in the spatial orientation, and therefore they become over dependent. But that is going to be the problem, because vision is not always reliable. Okay, because large field visual motion may be interpreted as self motion, which can cause them to have problems. Okay, so but what they give us at the end is a positive note. After all these things, they give a positive note, and that positive note is, fortunately, their symptoms can be improved by progressive exposure to visual motion stimuli and visuo-vestibular conflict during the rehabilitation program. So again and again, exposing them to visual motion and exposing them to the conflict situation is going to help them improve. This is what the final happy statement that they are making when it comes to this particular syndrome. So what other syndrome can they get into? These patients who have had a previous history of rotational vertigo, who are chronically dizzy. Motorist disorientation syndrome. The motorist disorientation syndrome is driving, particularly on motorways, that is highways, can be uncomfortable for patients with chronic dizziness. Occasionally, patients report a sensation that the car is tilting or veering to one side. Okay. This sensation can be compelling because often these patients see their mechanic or change their car before seeing the doctor. See this. That amount, the extent to which they believe this particular symptom that they are going through when they are driving, that the car is veering to one side or tilting to one side, it can be so compelling and so much that they can believe that they change their car or go to see the car mechanic before seeing their doctor. That much. This is what the hallmark motorist disorientation syndrome. This motorist disorientation syndrome also seems to be at least partly visually determined, because patients describe problems in visually deprived areas. Okay, where visually deprived, like top of a hill or a bridge, or in visually challenging conditions. two things he is telling. The patient will completely tell. Visual deprived area means they are on a bridge. There is not much to look right, left to help them orientate. There they have problems. The other problem is when the visually challenging conditions, simultaneously overtaking and being overtaken by a car. They are overtaking one side and one side they are overtaking. So on the left there is one car. On the right side, they are being overtaken by another car. At that time, it becomes very much difficult for these patients. Indeed, the coexistence of visual vertigo and motorist disorientation syndrome in the same patient is not rare. So when we say patients who are chronically dizzy now get into one of these particular these syndromes, named syndromes like visual vertigo, it is not that a person, this visual vertigo and motorist disorientation syndrome are mutually exclusive. They are not. They can be there in the same person. So, going round a bend as when negotiating a roundabout can also disorient patient. But here there may be a predominantly vestibularly mediated mechanism. It must be kept in mind that driving through a curve is different from just turning round while walking. The radius of curvature is large while driving, so the conditions are equivalent to being centrifuged, and that is why you are pushed sideways against the door. In this case, the unusual stimulation, sideways linear acceleration, acting on a damaged otolith system may be responsible for the symptom. In addition, non-congruent visual stimulation and the non-physiological posture on vibrating cushions which numb somatosensory inputs make driving a kind of sensory deprivation experiment in which vestibular asymmetries may re-emerge. See, what is happening is this particular person has had a previous history of rotational vertigo. There is some kind of an underlying damage that has already happened, and there is an underlying asymmetry in the vestibular system between the right, between the left. And this particular, it has for some reason, okay, there is an asymmetry for some because of some pathology. Now what is happening? This particular person is going through an experiment of sensory deprivation. You are making him sit on cushion, okay, or where the somatosensory inputs are numbed. The visual stimulation is unreliable. The person's posture is not really physiological. He is not sitting in the position in which he is supposed to be sitting. I mean, we are not in the normal walking around state. All these things cause it as a sensory deprivation experiment in which the previous asymmetries will suddenly become apparent, become unmasked, that is what he's saying, may re-emerge. Psychological components, usually in the form of panic and avoidance behavior, can be contributory as well. In fact, in patients with no vestibular history or finding, a psychological disorder may be the only mechanism responsible. In these patients, however, there are usually more panic symptoms and less veering and tilting of the cars. So, the weightage of the diagnosis towards a psychological disorder versus an underlying vestibular condition which has led to motorist disorientation can be based on what is the predominant symptom of the patient. Is the predominant symptom of being in the car, the predominant symptom, is it panic or veering and tilting of the car? If the person has gone to the mechanic before you come here, it is unlikely to be a psychological disorder. In patients with motorist disorientation syndrome comprising tilting car illusions, previous history or findings of vestibular disease, and no panic component, treatment will be based on vestibular rehabilitation, including additional visuo-vestibular conflict and optic flow simulation. So, in patient with motorist disorientation syndrome comprising tilting car illusions, previous history or findings of vestibular disease, and absolutely no panic component, in that case, what you will be doing is vestibular rehabilitation will include more visual vestibular, additional visuo-vestibular conflict, and optic flow stimulation. Means you give optokinetic stimulation. There has to be more and more of flow, optic flow, the visual, okay, more fast moving things, although present the subject with more and more of optic flow. In patients with predominant panic symptoms but no car tilting or non-vestibular disease, treatment is psychiatric, often combining medications, okay, that with cognitive behavioral therapy. You combine medications with cognitive behavioral therapy. The medications can be SSRIs or anxiolytic, any anxiolytic with cognitive behavioral therapy. So where are we? We started with chronic dizziness. In the chronic dizziness, we divided into 3 groups who began with acute rotational vertigo, people who are having progressive disequilibrium, and people who are not having progressive disequilibrium, who did not have a acute attack of, who did not have a rotational vertigo. Now, within the persons who are having a rotational vertigo, some patients refuse to compensate and they can have different kinds of named syndromes. In that named syndrome, we dealt with visual vertigo. We completed a condition called motorist disorientation syndrome. Now we will be getting into another condition which the same people who have had previous rotational vertigo can get into, and that is persistent postural perceptual dizziness. Persistent postural perceptual dizziness. You know, the name persistent came because in Europe, chronic is not liked because chronic is a bad connotation. That's what I mentioned before. The term perceptual is used because subjective again means that patient is imagining things, so they didn't want to do that. So perceptual, and that is it. And postural because it's there, it is definitely worsened in certain postures. So related terms: psychogenic somatoform dizziness, phobic postural vertigo, chronic subjective dizziness. In ancient medicine, vertigo and psychiatric symptoms were often regarded as the 2 phases of a single disorder originating from the brain. In contrast, modern medicine, with its predominance of the natural sciences, tends to neglect the psychological and behavioral dimension of vertigo and dizziness. However, give me a minute. However, emotions interact with orientation and balance in various ways and differently in different people. For example, healthy people may feel quite uncomfortable, anxious, and dizzy when they are exposed to heights. There are other individuals who feel and behave quite differently, including free climbers, parachutists, bungee jumpers, who are ready to risk their lives for the exciting experience of heights. Okay. Similarly, the emotional reaction of vestibular patients to their symptoms varies considerably, ranging from calm adaptation to the new situation to being frightened to death by a vertigo attack. In interaction of the mind and body may take the opposite direction as well. Patients with purely psychiatric disorders often experience and express their distress with somatic symptoms such as chest pain, dyspnea, diarrhea, headache, and quite frequently dizziness or vertigo. See, this very, very beautiful point. Person who is vertiginous may complain of, who has an underlying vertigo problem, may develop a psychological manifestations. The other way around, patients with psychological problems may actually express that in terms of somatic symptoms. And one of the somatic symptoms can be dizziness. So 2 things we have to see. This can lead to that, or that can lead to this. Okay, so both ways are possible. It is not that only psychiatric patients always come. I mean, psychological patients can come with it is possible that there is underlying psychological patients. So there are people who are stressed out who come and tell, I feel headache. There are people who are stressed out and feel chest pain. There are people who are stressed out who can also feel dizzy or vertiginous. On the other side, there are people who are having dizziness, who on one end can calmly adapt to that symptom. There are other people who can panic, and act totally differently. So these are the ways in which different people different people respond to similar things. Now, the clinical features. When it comes to the clinical features, Persistent perceptual dizziness is a new term that has been coined to integrate previous concepts such as phobic postural vertigo, chronic subjective dizziness, or more generally psychogenic dizziness. It is the second most frequent diagnosis after BPPV in specialized dizziness clinics. So the moment that you are getting, if you are making more diagnosis of triple PD or double PD, it means that you are in a specialized clinic. The term, okay, PPD stresses the chronic nature of the symptoms, while patients with panic disorder may have similar vestibular-like symptoms appearing in a paroxysmal fashion. See the difference here. In this patient with persistent, it tells that the symptoms are appearing chronically. In a panic disorder, they come vestibular-like symptoms appear in paroxysmal fashion, means they come in bouts and then they go off. One bout and then it goes off. The core of the PPD is persistent non-vertiginous dizziness or unsteadiness on most days for more than 3 months. Okay, non-vertiginous dizziness or unsteadiness on most days for more than 3 months. Anxiety, phobia, or depression are commonly associated, but may be lacking in individual patients. Anxiety, phobia, or depression are commonly associated, but may be lacking in individual patients. The intensity of symptoms may fluctuate spontaneously or in response to provocative situations. Dizziness can be more severe when walking or standing and less intense when sitting or lying. Exacerbations may be prompted by active or passive self-motion after a busy day, large visual stimulation, example by cinema screens, moving crowds, traffic, or supermarket aisles. Focused exposure to smaller visual targets such as reading or computer work may similarly induce symptoms. Okay, so this is the other thing. Focused visual targets. Okay, focused exposure to smaller visual targets may induce symptoms. Many patients also react to classical agoraphobic stimuli such as leaving the house, crossing a large square, looking down from heights, or to situations where they feel trapped such as elevators, aeroplanes, and queues at supermarket checkouts. Exacerbations may be superimposed by panic attacks and can be accompanied by catastrophic thinking, example, an unfounded fear of falling. Instinctively, most patients avoid this provocative situation. Thorough history taking identifies an initial trigger in most PPD patients, including a preceding vestibular disorder. This is the point here. They will have an initial trigger in most of these patients, and that initial trigger can be a preceding vestibular disorder like vestibular neuritis. It can be BPPV, it can be Meniere's disease, or it can be vestibular migraine. Any of these vestibular disorders could have started off this full maladaptive mechanism into developing a triple PD. Mild traumatic brain injury or whiplash, panic attacks, generalized anxiety, orthostatic hypotension, cardiac dysrhythmia, syncope, or medication side effects. So any of these things could have been an initial trigger, and with history taking, we will be able to figure out that initial trigger in most patients. That initial trigger could have been a medication side effect. It could have been an attack of syncope. Okay. So today the person is chronically dizzy. Previously the person has fallen. The way to put them together is that was a syncopal attack, and that has led to this. The two need not be a same medical condition. Okay. Only a few other dizziness disorders such as devastating brainstem or cerebellar lesion can be as incapacitating in the long term as PPD. Patients often feel unable to work, to leave the house unattended, to meet friends, or even to take exercise. Many depend totally on partners or other family members. Some even stay in bed for most of the day. What is the pathophysiology? Okay, we know the problem, we know the extent to which different people suffer, we know the different situations in which people suffer. Okay, now let us get into the pathophysiology. The mechanism leading to persistent perceptual dizziness can be regarded as a maladaptive strategy to cope with a stressful event, such as an acute vestibular disorder or a first panic attack with dizziness. These strategies are often useful at an early stage but become dysfunctional later on. Now he's going to see the concept that he is introducing, the authors are introducing, are a concept called maladaptive strategy. Adaptive strategy is one, maladaptive strategy is one thing. If we have a broken finger, not splinting that finger, not touching moving with the rest of it, but not touching that finger is an adaptation. But if you are so fearful that you stop using the entire hand, or that becomes maladaptive. Okay. So, for example, these strategies are often useful at an early stage but become dysfunctional later. For example, a cautious, small stepped gait is completely appropriate for the acute phase of vestibular illness, but detrimental when maintained longer than necessary. So, when the person has had acute vestibular neuritis, if they try to, if they are fast, they can disorient, maybe they will slip, maybe they will fall. So at that stage, they have to take a small stepped gait. But if you continue to have a very small stepping gait, then that will have problems with balance. Conscious monitoring of balance or visual motion cues can be stabilizing in the acute stage, but may turn into a source of persistent irritation in the long run. Similarly, heightened awareness for body signals may be protective when health is acutely endangered, but may lead to misinterpretation of physiological activity as imminent danger. So this is the key point here. Misinterpretation of physiological activity as imminent danger. Vestibular sensation is a dynamic sensation. Okay. And we need to move to engage the vestibular system. Okay. That is how the vestibular system works. We need to move to engage the vestibular system. Okay. Even some amount of movement that is needed to engage the vestibular system will be interpreted by these people as an impending fall. So this is the kind of thing that can be happening in these patients. Pre-existing anxiety. An example is, you can see, if any of you can stand on the foam. If you stand on a foam and then close your eyes, you will start shaking. That shaking is actually the vestibular system engaging itself to be able to help you from stopping a fall. That is how it is. But if that kind of engaging the vestibular system is actually interpreted as an imminent fall, then that can be. And if that happens even not on the foam, even on the day-to-day basis, then it can be disastrous, okay, as a sensation. All in all, okay, PPD is not a purely psychiatric syndrome, but rather results from a detrimental interaction of vestibular symptoms, psychological factors, and dysfunctional behavior. Many patients with PPD report the syndrome described above as visual vertigo or visually induced dizziness. The underlying mechanism of visual vertigo is visual dependency, a strategy that relies predominantly on visual information for spatial orientation and balance with a relative neglect of vestibular and proprioceptive signals. Visual dependency may represent a personal trait, or it can be acquired in the course of a vestibular disorder where ignoring erroneous vestibular signals and putting more weight on visual cues can be initially an adequate strategy. The consequence of visual dependency, however, is detrimental because in the absence of reliable reference, any movement of the visual environment may lead to self-instability and imbalance. In fact, see what happens in this particular person who becomes visually dependent means he starts giving so much more importance to what is happening in the visual field for orientation, for perception of balance and position, is that to the detriment of vestibular input and also the proprioceptive somatosensory input. So much of weightage they are giving only to the visual. Now, what will happen if such a person stands in front on the railway platform and a train moves in front of them very fast? When the train moves in front of them very fast, vision is telling them that they are moving to the other side. If the train is moving in this direction, if the vision tells, okay, you are moving in the other direction. And they try to compensate for that by rebalancing. But it is not actually rebalancing. They will end up, okay, becoming imbalanced. So this is the problem with being overly visual dependent. In fact, patients with visually induced dizziness sway more than normal controls when they are confronted with a moving visual scenes. Whether the visual vertigo is part of a poorly accomplished central vestibular compensation process as premorbid high visual dependence or as part of a psychological trait present in triple PD patients is not known. To some extent, this question is mostly of academic interest because the treatment with visual motion stimuli seems effective for the visual vertigo component per se, regardless of the initial mechanism involved, which means even patients with triple PD, okay, if they have a visual vertigo, okay, also in them, then the management would be like by giving a visual motion stimuli, just like the patient with visual vertigo. Now, clinical examination and investigations. Although clinical examination is mostly normal, there are many reasons why patients with suspected triple PD should be carefully examined. Examination may reveal an underlying bilateral vestibular failure, downbeat nystagmus, residual levels of BPPV. We made this thing. We spoke about this in the beginning. There was one patient who did, after vestibular neuritis, did not compensate for a long time. Why the person did not compensate was evaluated. There was also a BPPV, and only on treating the BPPV, patient started to compensate. So like that, there can be a residual level of BPPV. Peripheral neuropathy or other medical problem such as cardiac arrhythmia or postural hypotension. So therefore, though it is likely to return normal, still make sure that the clinical examination is completed. Specifically look for bilateral vestibular failure and downbeat nystagmus syndrome. Why these two things are coming here? We saw in the table right in the beginning, the authors talked to us about some conditions which cause chronic dizziness, conditions with physical signs and conditions without physical signs. And in that, they talk about bilateral vestibulopathy, vestibular failure, and downbeat nystagmus. And these two things were specifically mentioned first, not because they are very frequent, but they can be easily missed. So if you should not miss them, even a person whom you know it is triple PD, make sure that we do a thorough clinical examination so that we don't. And here, examination may reveal underlying bilateral vestibular. The first two things here, bilateral vestibulopathy and downbeat nystagmus. The first two things that mentioned elsewhere. Residual levels of BPPV, peripheral neuropathy, or other medical problems such as a cardiac arrhythmia or a postural hypotension. So that is why simple techniques like testing for BPPV, testing for downbeat nystagmus, both directly and under a video frenzel with on removal of fixation. A simple head impulse test to the right and to the left for bilateral vestibular failure. Peripheral neuropathy, vibration sense in the lower limbs to check for peripheral neuropathy. Simple vibration sense, 128 Hertz tuning fork, or if you have a specific device to test vibration like a VibraSense device. Or other medical problems such as cardiac arrhythmia or postural hypotension. One blood pressure examination, lying down, getting up at different time intervals. We do make the patient lie down for 5 minutes. Okay, from the learnings what we got from Dr. Vishal Pawar. 5 minutes lying down. Then on getting up 1 minute, 3 minutes, 5 minutes, and 10th minute, we take the blood pressure. And 1 full minute of pulse, taking the pulse, has revealed cardiac arrhythmias in a few patients for us. So in these conditions, which require treatment in their own right, may have triggered the development of PPD, but usually cannot fully explain the intensity of symptoms and the resulting handicap. Clinicians may refer to this as a degree of functional overlay. Another good reason to examine these patients and to perform laboratory tests is to gain their trust. Okay, this is very important, to gain their trust. They have come to see you as a dizziness doctor, not as a psychiatrist, unless they feel that you have the broad range of clinical skills required to make a diagnosis, manual and verbal. Patients may not be open enough to discuss contributory emotional aspects. In fact, in our clinic, sometimes patients open up to us on the 3rd or 4th visit. We have seen patients who call up and open up to us. Okay, they come with the spouse, and there are other times when they just call up when the spouse is not there, they only call up, and then this is the problem that I have been going through. That emotional aspects comes up after some time. So though in the beginning only we may feel like, okay, there's a lot of underlying psychological conditions, it is important to examine them. Okay, only then these things may come. It may not be a good idea to straight away get into the emotional aspect. Formal psychiatric consultation can be useful for proper diagnosis of the psychiatric aspects of and for specific treatment recommendations. Quite often, however, patients do not meet all diagnostic criteria of established psychiatric syndromes, and their conditions can be better understood by a dizziness doctor who knows about the behavioral consequences of vestibular disease. Finally, a word of caution: do not order too many tests, as this may convey the message to your patient that he or she may still have a rare undiagnosed condition. Moreover, you will have to deal with false positive results or minor abnormalities which do not sufficiently explain the patient's condition. Do not deceive yourself and your patient by thinking that 2 or 3 tiny white spots in an MRI or a 10% caloric canal paresis explain major symptoms and psychosocial disability. This is very, very important point. So in MRI, a few white spots, flare, hyperintensity is very commonly reported. Okay, that should not be taken as an explanation for the patient's problem. 10% caloric canal paresis. So this is what I tell. The idea of vestibulometry, when we do a lot of vestibular investigations that we do, the idea of vestibulometry is insight, not numbers. Okay, it is insight, it is not numbers. In fact, I tell people not even to look at the numbers there. See the patterns, see what is happening there, what kind of nystagmus, what kind of graph, and how it relates to your particular patient, rather than going by the numbers. Okay, the idea of vestibulometry is insight, not numbers. Don't throw out numbers. 5% caloric paresis, 10% caloric, 35% asymmetry, horizontal canal 10%, lateral canal, gain 1.5, gain 3.2. No, the idea is not numbers, it is insight. Treatment. How to inform patients about their condition. The patient's reaction depends, in our experience, largely on the doctor's ability to communicate and to establish a trustful relationship. Telling the patient it's all in your mind is a very, very bad start. 2 things to avoid: it's all in your mind. Second thing to avoid, you will have to live with it. 2 things please avoid. Telling the patient it's all in your mind is a very bad start. You have to live with it is a very bad end. Okay, 2 things avoid in patients. Okay, in any case, a potential negative reaction by the patient should not influence our diagnostic decision, but rather prompt us to customize the wording when discussing the diagnosis with the patient. It is more important to convey the key messages to the patient than to use psycho words. A good starting point can be the reassurance that health anxiety, cautious movements, and avoidance of symptom-provoking situations are normal initial reactions to vestibular disease and other stressful events. So what you are now going through is a normal initial reaction. The problem is that it is what is normal initially. After being sure that nothing else is going on, persistence of that is the problem, but your behavior itself is normal. That you are anxious about your health is good. When you suddenly become vertiginous, that you become worried about your health is a good thing. You are moving cautiously is a good thing. You are avoiding some things that provoke your symptoms is a good thing, as an initial reaction only. Okay. The vicious circle of high anxiety levels producing somatic symptoms, which then tend to even more worry, can be explained in simple terms. The patient usually agrees when the doctor supposes that the dizziness has gradually gained control over his or her life, telling him or her what to do and what to avoid. Means you are not telling your body what to do. The dizziness is controlling you. Most patients approve the therapeutic goal to regain their autonomy unless some secondary gain hinders them. Okay, this secondary gain can be whatever. From there, it is only a small step to the concepts of vestibular rehabilitation, cognitive behavioral therapy. These treatment approaches often need to be combined, particularly when patients have been off work for several weeks or months. Resuming sports and learning a relaxation technique such as progressive muscle relaxation should be encouraged because of their sympatholytic and anxiolytic effects. In addition, sports promote a sense of self-efficacy and body confidence. Some patients, example, an elderly person will, with fear of falling, may not be able to or may not wish to undergo psychotherapy. Vestibular rehabilitation can be even more effective in this situation as it ideally integrates physical training and psycho-behavioral interventions such as graded exposure to challenging tasks, reassurance, and cognitive reframing. When visually induced dizziness is a predominant complaint, vestibular rehabilitation should focus on visual desensitization by exposing the patient to visual motion stimuli of increasing size and duration. See, how we can do this is visual desensitization. You can take a screen. Just on YouTube, you can find optokinetic stimulus. Okay, any pattern. Play that on the screen. If you have access to video nystagmography, you have an optokinetic screen, even better. Play that pattern on the TV screen, but start off by the patient standing at a distance, which means only 10% of their visual field is covered by visual motion stimuli. But as the days and weeks progress, you bring the patient closer and closer to the screen. Finally, they will be so close to the screen, the entire field will be covered with that. And that is how you desensitize them to visual motion. So visual motion stimuli of increasing size and increasing duration. This can be done by large field optokinetic stimulation in a vestibular laboratory or by using a disco mirror ball. This disco mirror ball, even we can also use these. There are lights which are available with a rotating disc, which will flash optokinetic stimulus on the wall. Alternatively, patients can be exposed incrementally to visual motion in their usual environments, including supermarkets, traffic, or TV or computer screen. Several open label studies have shown that persistent perceptual dizziness may respond to serotonin reuptake inhibitors. We are, however, cautious with respect to SSRIs because controlled studies are lacking and both their use and withdrawal may be associated with increased levels of anxiety. Treatment should follow a slow and low regime, example by starting with almost 5 mg of paroxetine with increases to 10 or 20 mg after 2 and 4 weeks. This approach makes full use of the placebo effect, which seems to be a major action of this class of antidepressant, while minimizing side effects such as nausea, sleep disturbance, and sexual dysfunction. If the underlying disorder leading to triple PD or double PD is vestibular migraine, old-fashioned tricyclic antidepressants such as amitriptyline taken at night may improve mood levels, promote better sleep, and treat the migraine disorder prophylactically. As triple PD patients are highly body vigilant, one should minimize the side effects, mostly constipation, somnolence, dry mouth, by starting low and going slow. So 2 drugs which are specifically mentioned here by name are paroxetine and amitriptyline. And the message to use the drugs is slow and low. Here, low, starting low and going slow. So slow and low. Starting low and going slow is what it is. The reason, use the placebo effect, minimize side effects. And then when it comes to if the present patient today is having triple PD, but the underlying trigger, see where are we in this particular entire discussion? We are in the group of patients who are chronically dizzy now, but it all started off with an acute vertigo. If that kind of it all started off or has a rotational vertigo too, if the person that rotational vertigo cause is actually vestibular migraine, in that case, for this patient, a good choice of medicine would be amitriptyline taken at night. Some other psychiatric dizziness syndromes. Dizziness of psychiatric origin is found not only in anxiety disorders, but also with depression and somatization disorder. Dizziness due to depression is usually less dramatic in its presentation and is often described as a swimming sensation. Okay, Dr. Pratik, okay, is the one who introduced this sensation to us to tell us about some patients complaining of this. Dizziness due to depression is usually less dramatic in its presentation and is often described as a swimming sensation. Depression, dizziness, swimming sensation, or an inability to concentrate. It tends to be continuous rather than paroxysmal. Associated symptoms include depressed mood, lack of drive, fatigue, sleep problems, and loss of appetite. Dizziness due to a depressive disorder usually disappears when the underlying illness is treated adequately with antidepressants or psychotherapy. Somatization disorder, formerly called hysteria or conversion disorder, is characterized by multiple repeated somatic complaints and symptoms without an identifiable cause. These patients may present with a subjective complaint of dizziness only, or with non-organic ataxia, bizarre gait disorders, or even inability to stand in the absence of any abnormal neurological findings. Okay, you can see this figure. You ask the person to stand, they start falling. Okay, they start, but they will not fall. In the sense, when they fall, they will fall towards you. On the other side, they veer so much, but then without falling. You will immediately realize that a person who actually has a real balance problem would not be able to do so much of gyration and yet not fall. If the person is gyrating so much and yet not falling, then it could be a somatization disorder. Okay, it is also called as a psychogenic pseudo-ataxia. Note the discrepancy of the swaying trunk in the presence of stable stance and the improvement by distraction while the patient is asked to recognize numbers written on her arms. Again, this concept Pratik only told us. When the person is here, okay, full falling off and all these things, you can see the lower half of the body is straight, upper half is what is gyrating. Okay, this is seen in psychogenic pseudoataxia. The other thing is, if you try to do a distraction test by writing numbers on the forearm, okay, by writing numbers on the forearm. Just give me one minute. Hello, I'm still on the meeting. Meeting chal raha hai. Hello, yeah, okay. So this is psychogenic pseudoataxia. Then two more conditions in this patient who started off or who has rotational vertigo in addition to persons having chronic dizziness to know is chronic vestibular migraine and late stage Meniere's disease. So chronic vestibular migraine, like migraine itself, vestibular migraine presents with attacks rather than persistent dizziness. This is the way in which vestibular migraine presents. But a small subgroup of patients progresses from episodic vertigo at the beginning to chronic dizziness later on. At this stage, patients usually suffer from a constant seasick sensation of fluctuating intensity, which is aggravated by head movement or visually challenging environment. This is a stage of chronic dizziness. They're always seasick, always some kind of nausea feeling, okay, and which is aggravated by head movement or visually challenging environment. Sometimes they also experience superimposed attacks of spontaneous or positional vertigo. Typical migraine headaches can be lacking but should be unearthed from the history by specific questioning. Means previously they must have had. Again, inquiring about the early stages of the disorder is useful to make the diagnosis. Chronic vestibular migraine may be maintained or aggravated by psychological and behavioral factors, particularly anxiety, panic attacks. See what we are talking about, what maintains the chronic vestibular migraine. Why did somebody become chronic migraine person? It is being maintained by a psychological and behavioral factors. What are these factors? Anxiety, panic attacks, increased body vigilance, and avoidance of symptom-provoking situations. This syndrome has been designated as MARD, migraine and anxiety-related dizziness. The relative contribution of organic and behavioral factors is usually hard to disentangle in this type of patient. But what can we do about these people? treatment often requires a combination of migraine prophylaxis, vestibular rehabilitation, and cognitive behavioral therapy. Then the last thing to know in this particular group of patients who started off with rotational vertigo or also have rotational vertigo in addition to chronic dizziness is a late stage Meniere's disease. This is like burnt out Meniere's disease. Meniere's disease starts with episodic vestibular and cochlear symptoms, and there is a complete resolution of symptoms in between attacks. This is how Meniere's starts. As the disease progresses, patients develop permanent hearing loss and tinnitus, and later sometimes also chronic dizziness and disequilibrium because now the inner ears are completely damaged. After 10-15 years of the attacks may eventually disappear, while the chronic dizziness persists due to permanent damage to one or both labyrinths. This is like saying that this person previously had Meniere's disease, now has developed bilateral vestibular failure. So something like that. So now these are the 5 ways in which these persons who have 5 different diagnostic conditions or groups or syndromes which people will go through. Late stage Meniere's disease, chronic vestibular migraine, triple PD or double PD, whatever you want to call it, motorist disorientation syndrome, and visual vertigo. Now going to the next group. Okay. Now going to the next group, patients with progressive disequilibrium. In view of want of time, I would want to start summarizing at this particular point of time, but I will summarize with going through the next few points in the chapter. Progressive disequilibrium, what are the things to consider? The things to consider is bilateral loss of vestibular function. Then we have to think in terms of neurological disorders causing progressive disequilibrium. Okay. So oscillopsia during head movement, bilateral vestibular loss, persistent oscillopsia, downbeat instinct. We made this point early on. Person also, when it comes to neurological gait disorders, memory loss, urgency of urine, maybe there is a normal pressure hydrocephalus, or maybe there is cerebral small vessel disease. These are common in the vestibular clinic. If you seek them, you will get it. So ask for any urinary urgency and memory loss. Cervical spondylotic myelopathy, they will have numb, clumsy hands, leg spasticity, and ankle jerk, knee jerk will be highly exaggerated in this kind of patients because cervical spondylosis is pressing on the spinal cord. Myelopathy is spinal cord anterior columns. Okay, that will cause spastic, okay, lower limbs. Motor incoordination, if there is, and dysarthria, cerebellar ataxia, if there is numbness or weakness in the distal ankle jerks are absent, vibration sense is less. Think in terms of polyneuropathy. There is slowness if the patient is not able to do rapid, repetitive movement, not alternating movement, we're talking repetitive movement. Then, or if there is a reduced, and then if there is tremor, resting tremor, then think in terms of Parkinsonism. These are the neurological conditions. Towards the end, patients with no history of vertigo or disequilibrium. And here I want to see what the author wants to tell. I want to read this part to you. Because this is one condition where this also tells, like when we are feeling lost, even people with a lot of experience dealing with these patients also seem to feel lost. Okay, see here. Sometimes patients refer to a sense of vague and chronic dizziness with no history of true vertigo nor disequilibrium. Direct general health questions may guide to disease-specific organs or systems. There may be anemia, thyroid problem, drug toxicity, but this line of inquiry is usually negative. A full clinical examination is warranted, including checking blood pressure, supine and standing if the history suggests orthostatism, which we would have picked up even by the pro forma which we had before. Okay. This is a difficult patient group to diagnose, and numerous investigations are often required, including blood tests to rule out general medical conditions such as anemia, hypothyroidism. Anemia can be there. Hypothyroidism, especially in the elderly, okay, there can be hypothyroidism. Other endocrinological conditions, diabetes, hypoglycemia, brain scans, and vestibular function tests. With a history that is not disease-specific, an anxious personality, and negative investigation, Many patients are diagnosed as having psychogenic dizziness, rightly or wrongly. The acceptance of the concept persistent perceptual dizziness by the vestibular community has made the job of diagnosing psychogenic or psychosomatic dizziness somewhat easier, because at least we have an escape route by giving a name to this particular patient. Observe during history taking whether the patient appears to hyperventilate and inquire about frank hyperventilation and anxiety episode, as well as features that may indicate hyperventilation such as perioral paresthesia. In our opinion, the active hyperventilation test is not so reliable because hyperventilation induces dizziness and unsteadiness in everybody, not only in patients with hyperventilation syndrome. So when is hyperventilation test really beneficial? Only when the patient recognizes his or her own typical symptoms during the voluntary hyperventilation is the test useful. Blood gases and the opinion of a chest physician may be justified in some cases. Coming to, so what I've skimmed through or skipped through is patients who come to us with progressive disequilibrium. Not the first group we went in detail. The second group, progressive disequilibrium, we are just brushing through, and most common cause of that is bilateral vestibular function, bilateral loss of vestibular function. They have problem with oscillopsia or reduced acuity of vision, less clear vision when they are walking around, when they are moving around. So this is what happens in bilateral, and we can pick them up by vestibulometry in terms of doing a caloric test, in terms of doing a dynamic visual acuity testing, or by doing a video head impulse test, or even a clinical head impulse test, bilateral loss of vestibule. If you know it, if you seek it, you will get it. And these patients cannot stand with eyes closed on foam for even 10 seconds. They will fall immediately. So that is how the thing happens in bilateral vestibulopathy. So then we went into neurological disorders. Then we went into the one patient in whom patients with no history of vertigo or disequilibrium. So all the three conditions we have seen. Now coming to the management of the chronic disease patients, there can be disease-specific patients, non-disease-specific pharmacological treatment. I will just go through that very fast. Disease-specific patient, if an active underlying vestibular disorder is identified such as BPPV, migraine, or Meniere's disease, this needs to be treated as outlined before. This is particularly important because with each vertigo attack, the patient's chronic symptoms and anxiety tend to increase. By the same token, do not assume that the patient is in a chronic phase. He may not, for instance, have active BPPV. No, don't make that assumption. After months or even years of experience, patients with BPPV develop complex but effective strategies to avoid the offending head positions, and in extreme case, develop a phobia of lying down. In these cases, if you find active BPPV, you can treat it with repositioning maneuvers. If there is no BPPV, you can begin to reassure your patient, thus engage him more diligently in an active rehabilitation program. In summary, always try to establish whether your patient still has episodic attacks. Always examine your patient, even if he or she denies having them, which means test for positional testing is mandatory. In spite of the patient not complaining of positional vertigo, positional testing is mandatory. That is the underlying statement. And personally, it has helped me a lot of times when even patient does not completely denies positional symptoms and positional testing shows that it is BPPV. After that, it's a very, very fruitful experience. Non-disease specific pharmacological treatment. Vertigo or nausea can be improved with medication, and these are very useful for acute attack or recurrent episode. Always inquire about medications your patient is taking. Most experts now believe that long-term use of vestibular suppressant and tranquilizers is counterproductive for the process of vestibular compensation. These drugs should be used only for the true acute vertigo phase and stopped as soon as vertigo begins to recede in a few hours or days. Explain briefly to your patient the process of vestibular compensation, and that for compensation to occur, the brain must feel some vertigo. This sensation functions as a warning signal driving the compensation processes. Explain that no vertigo at all means no warning signal and hence no compensation. Sometimes it is difficult to wean patients off medication they may have taken for a long time, and one has to compromise and let the rehabilitation begin before the complete medication withdrawal. So tell, okay, fine, you are not able to take them off. I want them off, but you are don't want to. Okay, fine, I will compromise. You start the rehabilitation. Once you are confident after the rehabilitation process, then I will start reducing your medicines. Patients with migraine or vestibular migraine overusing painkillers will benefit from switching to prophylactic medication. It may be useful to implement this switch before starting the rehabilitation process, as migraine symptoms may initially increase during eye, head, and visual motion exercise induced required. This is again an important point. The moment you start rehabilitation, migraine patient starts worsening. So start off the prophylaxis before you start the rehabilitation. General support, reassurance, information, and counseling are extremely important. Explain in simple terms the process of vestibular compensation and that sometimes, with or without obvious reasons, compensation is incomplete. Provide useful web pages, leaflets, explain the need for rehabilitation, and try to motivate your patients to participate actively in their own recovery process. And there is a note on the kind of rehabilitation that you can give. Okay. And then we have what to do if you don't have a clue. Okay, there are times that all the knowledge put together, we are not able to help, and what we can do. Do not miss. Okay, if you want to take a screenshot here, you can take this. Okay, what exactly the rehabilitation? What to do if you don't have a clue? You can take a screenshot, because I know that we are overshooting the time. It is 10 o'clock. It is time to, I think, stop. This was one. I wanted to give this particular experience of going through this reading. This is the kind of reading we do in the clinic, and this is the kind of reading we used to do during the COVID pandemic, early mornings. Okay, getting up at 5 o'clock. And thank you all for participating. I saw all of you were there, glued here together. Thank you so much. Okay, and that
Thank
book,
you, sir. Thank you very much.
Thank you, sir. The book name is
Thank you.
Adolfo Bronstein's Dizziness, Adolfo Bronstein. It's available on Amazon. It's available somewhere. Keep that as a desktop guide. Okay. Okay. Keep that there on the table all the time. It'll be great. It'll be beneficial to great extent. Thank you all. I'm seeing a lot of thank you messages on the chat box. Thank you so much. I think Dr. Pratishta has something to say. Yes, ma'am. I'm reading all the chat messages. Thank you all. Thank you so much. Thank you all.
Sir, today I have seen one patient. He's a banker and has the similar complaint, like he's feeling like he's floating, leg is floating on the surface, and he's a diplopia also. Sometimes he's sitting most of the time in the computer, and there is a no spinning sensation. But while he is standing, he just feel that he is dizzy, or he's imbalanced or unsteadiness. Then I think so it's a case of the real PPD, whatever
Yeah.
I have.
Yes.
Yes, sir.
I think today would make you go back more confident about that particular patient's diagnosis that you reached.
Yes, sir. Thank you so much, sir.
Thank you.
Then-
Name of the book is Dizziness by Adolfo Bronstein. I will open the screen and I will share that with you. I think some of you are asking for the name of the book. I will show the name of the book.
Sir, I had another interesting symptom last week. The thing
Okay,
is, one person, he would like to go to one side. Suppose right side is Kerala. I want to go to Kerala. So, but by mistake, he will drive to left side. While he's driving, he's aware that he's taking the wrong turn, but still continue. So that is the first symptom which I heard.
Okay. I think that may not be related to this particular. That is confusion. Turning to right, turning to left. That may not.
Yeah, and all the symptoms are of this.
Yeah, but yeah. So this is
all
the
the symptoms will have of this.
Okay, ma'am. What? Okay, ma'am. So I think you can see the name of the book. This is the name of the book. Whoever wanted to see that. Okay, fine. Yes, ma'am.
Sir, what we will do in this case?
Ma'am, Danya ma'am was saying something. Danya ma'am was saying something. Danya ma'am.
Sir, yes.
Yes,
sir.
ma'am.
No, sir. This patient, no, they have
Yeah,
all the
first
other
time you
things
said
of
it.
chronic subjective dizziness, 7-year duration, start after trauma.
Okay.
But this was another additional symptom which he was telling, like when,
Which you are thinking.
when he wants to turn to right side, he'll go to left side, and he knows that he is taking the wrong turn,
and
but
still
he
does
cannot
it.
do control it.
Okay. Okay. So maybe that particular thing, I don't know, even this Bronstein, when we read also that kind of a mention was not made. Maybe that is that is a separate confusion that the patient is going through. Okay. So yeah, I think there are more comments. Dr. Ramesh Rohiwal is saying, okay, disembarkation syndrome sometimes mistaken for triple PD. Yes, sir. True, sir. True. So, sir, I own this book, Dr. Anju. It's a great experience reading this. Thanks a lot. Thank you so much. Thank you. I think Dr. Karthik has shared some picture. I think it must be the book name. I'm not sure. Is that the book name? Okay. Dr. Sona has already read the chapter. Zubair, thank you. Chandrakanta ma'am, thank you. Yeah, Omkar sir. If you can add something in the section of what is, we don't have a clue. Yes, sir, I will
So
share.
basically, any additional points, sir? in that?
You want me to reshare the presentation, or I will send a screenshot to you? Okay, I'll take a picture.
Yes, sir. I have read that.
Uh-huh.
I'm asking you anything from your own personal experience which you want to add to this list of what is, because that is generally the case. We don't
The
have
one
a-
thing that I want to add from my perspective is this. Tell the patient, I will hold your hand as long as you hold my hand. In the sense, till you find a solution, I'll be with you.
Okay, sir. Okay.
Okay, that helps. That helps. Okay.
Okay, sir. Thank you, sir.
Thank you, sir. Thank you, sir. So,
Thank you, sir.
Dr. Devi Prasad, Dr. Anju, thank you all. So, thank you so much. I think with that, if we start, I know a lot of you will start sharing a lot of experiences. Okay. Dr. Pratishtha, you wanted to say something?
Sir, what should I go through? I have read it, but in this patient, escalating motor complexity is abnormal. All four are the abnormal.
So what
And
we will do, I think we will take that this discussion, I think, offline, because there will be some amount of discussion we will need to do.
Sure, sir.
Okay.
And thank you so much, sir. This is a
Thank you,
great
thank you.
experience.
Thank you so much. And thank you everyone for joining. I can see Dr. Vishal has joined, sir. Thank you so much for joining. Dr. Chandrakanta has joined. Thank you. Okay. Thank you so much.
Thank you very much, sir.
Thank you all. Thank you. Thank you. Ramesh Ravi, sir. Thank you, sir. Thank you all. Thank you. Thank you so much.
Thank you, sir.
Thank you, sir. I can see Dr. Atul Patil. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you. So with all your permission, we will, thank you, Dr. Rajshekhar. So with all your permission, okay, we will call it a day. Have a great evening. Have a great night. I mean, good night to you all. Thank you so much.
Thank you, sir. Thank you so much.
Thank you, Dr. Ravi Kishore. Vishnu, I think you can end the meeting, Vishnu.
Sure, sir. Thank you.
Thank you, sir.
Thank you. Thank you all. Thank you all.